So it's my pleasure to introduce our next speaker, Dr. Ali Yassen. Ali is our newest member of our cardiology team at NCMA, and he has a very international background. His medical school was completed at the Royal College of Surgeons in Dublin, Ireland, and then he went on to come back to the United States and go through residency at the College of Virginia. And a fellowship in cardiology there, and then interventional cardiology at Dartmouth. So we're very honored to have him in our practice, and we're looking forward to his talk this morning. Ali?
All right, good morning, everyone. Thank you for joining us today. Seems like a big crowd here. What I'm going to be talking about today is a topic that I think is more or less overlooked and underemphasized in our rapidly growing field, and that is same-day discharge after elective PCI. And I just wanted to start off by showing this picture because I think it truly portrays how far PCI has come since its advent 30 to 40 years ago. Not only in terms of technological advances, but also in terms of its increased utility as an outpatient procedure. So cath labs nowadays are really operating kind of like a drive-through fast food restaurant where patient drives in, we do the procedure, and we send them on their way. Not really, but you know what I mean. So just to start off with some background, before 2007, PCI procedures were reimbursed at the same rate, whether they were done as an inpatient or an outpatient basis. And then in 2007, Medicare got smart, and they were like, wait a second, inpatient procedures should be reimbursed at a higher rate. So that's what happened. Patients who come in with something like an acute coronary syndrome, they undergo an inpatient PCI procedure, they're reimbursed at a higher rate compared to those who come in for an outpatient elective PCI, and those patients are reimbursed at 28 to 38% less overall. So outpatient PCI is usually defined within a 24-hour period, and the important thing to note is that the reimbursement is the same regardless of whether the patient stays 2 hours after the procedure or 24 hours after the procedure. So not to get too specific in terms of the terminology, but outpatient PCI can be divided into two subgroups. One is same-day discharge, patients who are discharged within a few hours after the PCI, and those patients who are kept for overnight observation. The important thing to note is really that the reimbursement rate is essentially the same for those groups, so it doesn't really matter how long they stay. This is a flow chart showing kind of the different pathways, the different avenues that patients who present for outpatient elective PCIs can go through. What we're seeing more and more is that patients are being discharged on the same day after a successful, uncomplicated elective PCI. Some of the CMS-defined criteria for keeping patients overnight are things that make sense, like refractory nausea, vomiting, electrolyte imbalances or disturbances, arrhythmias, congestive heart failure, and so forth. And then patients who have a complicated procedure or have poor procedural outcomes, those are changed into inpatient status and kind of have a different pathway. So this chart kind of looks at the percentage of same-day discharge after PCIs over time. And what we can see from here is that between 2009 to the end of 2013, the rates of same-day discharge after PCI are really quite low, almost negligible. And then around the fourth quarter of 2013, with the spike in radial PCIs in the US, you see a concomitant spike in same-day discharge after elective PCI, which makes sense, and you could see it climbing steadily through 2014. And this was further shown in this temporal trends graph from the NCDR cath PCI registry. And the green represents same-day discharge, the red represents overnight observation. And what you can see is that over that same time period, there's a shift in balance in favor of same-day discharge instead of overnight observation. So I mentioned earlier that with the spike in radial PCI, you saw that correlated with a spike in same-day discharges. This was noted in a study back in 2017. And this is a survey of about 500 interventional cardiologists, half of which were in the US, the remaining in the UK and Canada. And if we focus on the left side here, that represents same-day discharge. What we see is that 40% of interventional cardiologists who did radial PCI would discharge their patients that same day. And that's compared to only a quarter of that, which is 10%, who did femoral PCI followed by manual pressure, discharged their patients the same day. And then those who did a femoral PCI followed by vascular closure device, which is represented by red, was somewhere in between. And that makes sense because, as we all know, radial PCI is associated with less bleeding and vascular complications, and it means that physicians are going to be more inclined to let their patients go that same day rather than keeping them overnight. So looking into the survey, just breaking things down according to country, the US, Canada, and the UK, what you see is in the US, actually only 14% of interventional cardiologists discharge their patients home the same day after PCI, and that's compared to 32% in Canada and a whopping 57% in the UK. So we're still kind of lagging behind in this tradition. So what are some of the concerns physicians have after PCI? Most cardiologists worry about ischemic complications such as stent thrombosis causing MIs, worry about bleeding and vascular complications, and of course you worry about death after PCI. Other things include readmission after PCI for things like angina, arrhythmias, congestive heart failure, and so forth. You also have to think about what's the appropriate length of stay after PCI, and of course, lastly is healthcare costs. And sometimes it's just very simple reasons why we keep patients overnight, and the procedure may just be late in the day, and it's kind of just tradition. It's the way it's always been done. So why do we really need to change practice? So what we're going to look at in the next couple of slides is I'm going to show some of the data to see if these concerns are really warranted and if same-day discharge is actually a safe and feasible option. So the first thing is procedural and post-procedural complications after PCI. And this is kind of a very complicated slide, but this is a 2016 report taken from 4 ACC and CDR registries. And it's a compilation looking at over 600,000 patients who underwent PCI for a variety of reasons. And they essentially looked at their complication rates. What they found was that the overall in-hospital complication rate for PCI was around 4.8%. But if you look at some of the more serious complications like stroke, it was about 0.2%. Congestive heart failure was 1.4%. Bleeding within 72 hours requiring blood transfusions was 1.6%. And then in-hospital mortality was 0.9%. So an important thing to take away is overall very, very low rate of periprocedural complications after PCI. So when we're looking at these complications, of course we want to know the timing because that'll be important to see if it's going to be safe to discharge a patient home the same day. And this was really looked at in 2 studies. One of them, the STRIDE study, which is a cohort of 450 patients undergoing radial PCI who were evaluated for adverse events between 6 and 24 hours after the procedure, because that's the time of overnight observation. What they noted was that 24 patients had complications. 20 occurred within the first 6 hours after PCI, and none occurred between 6 and 24 hours. So overall, low procedural complication rate of around 5%, and none of the complications would have been impacted by keeping the patient overnight since they all occurred within the first 6 hours after PCI. So they essentially concluded that same-day discharge following radial PCI is safe and feasible. And then this was corroborated by a larger, higher risk study called the Discharge study. This involved over 2,000 radial patients who were assessed for post-procedural events. And among the higher risk patients who were kept overnight, all complications were identified either within the first 6 hours or after 24 hours, and none were identified between the 6 and 24-hour range. So low overall complication rate, and adverse events occurred within the 6 hours post-PCI. They would not have been impacted by overnight observation. So essentially, if we look at these two studies, they noted that the likelihood of complications occurring beyond 6 hours after PCI, particularly during the period of overnight observation, is really quite low. So this is a study that looked at the rate of readmission according to length of stay, and this was published last year. What we found is, if you look on the left side here, patients who were discharged the same day, the rate of readmission was about 4.75%, which is really comparable to patients who were kept overnight. And then patients who were kept even longer had a higher rate of readmission, most likely because they were complicated, higher risk patients. So what about some of the causes of early readmission after elective PCI? The patients who were discharged the same day are represented by the blue bar here. And what you can see is whether they were readmitted for angina, acute MI, arrhythmias, or heart failure. Same day discharge patients had pretty similar readmission rates to those who were kept in the hospital longer. Maybe a little worse for acute MIs, but. So more studies, I'll just go through this real quick. Association of same-day discharge with serious complications such as mortality, bleeding, and AKI. If you look at the graph here, that represents same-day discharge. This is non-same-day discharge. And you can see, again, the complication rates for all of these serious complications is really quite low. And then a paper published in 2013 did a huge meta-analysis of 13 studies comparing same-day discharge versus overnight observation following uncomplicated PCI. And the primary outcome in this study was they were looking at total complications, they were looking at in-hospital mortality, and they were looking at 30-day readmission rates after PCI. Basically, what they found was that overall there was a very low event rate in both groups, and they concluded that same-day discharge after uncomplicated PCI is a reasonable approach in very select group of patients. And then a paper published more recently in 2016 looking at current perspectives. PCI is safer due to advancements in technique, technology, and pharmacology, and the length of stay has decreased over time. Most patients are discharged within 24 hours, and many patients can actually be discharged within the same day after PCI. So I just wanted to shift gears real quick and just highlight a point about early discharge after PCI for STEMI patients. This was a study, it was a single center retrospective analysis of almost 2,500 STEMI patients who underwent PCI and were either discharged early, less than 48 hours, or discharged late, more than 48 hours. And the authors did a good job at propensity matching, meaning making sure the two groups were equal, relatively equal in complexities and risk. And what they found was that looking at this Kaplan-Meier curve of mortality outcomes, the blue represents same-day discharge and the green represents, not same-day discharge, the blue represents early discharge and the green represents later discharge. What you find was that there was higher survival rates with early discharge compared to late discharge. And so they concluded that discharging low-risk STEMI patients within 2 days following PCI is safe and feasible. Obviously, I'm not advocating that we should try to discharge STEMI patients within 2 days, but what I'm saying is if you look at this higher risk, more complex patient group, and if they can be discharged safely within 2 days, then advocating for same-day discharge following elective PCI is really not an unreasonable option. So just moving quickly to cost, something makes sense to all of us. The less time patients stay in the hospital means that the less costs to the healthcare system. And this is a study looking at costs for both radial PCI and femoral PCI. And what they saw was that radial PCI is, of course, cheaper than femoral PCI, and same-day discharge costs $3,500 less than non-same-day discharges. So if you combine the two cheapest pathways, radial PCI and same-day discharge, the healthcare system saves about $3,700 per patient compared to the usual pathway of femoral non-same-day discharge. And then this was again seen in another study called the EASY study, 1,000 patients who were randomized to either same-day discharge versus overnight observation, and they showed that same-day discharge resulted in a 50% relative reduction in healthcare costs. And that's noted in the chart on the right here. That shows cumulative healthcare costs per patient within 30 days post-PCI. And the hospital saves $1,141 with same-day discharge versus overnight observation. So just to summarize, why would we do same-day discharge? I mentioned a lot of the data in the previous slides showing a low overall post-procedural complication rate. You have reduced overall costs. It frees up bed space for patients who may need that level of care. And PCI centers that are major referral centers may realize advantages of same-day discharge. It increases bed availability to transfer other patients in who really need inpatient care. Also been shown to result in greater patient satisfaction, and it turns out that patients actually prefer to spend the night in their bed at home rather than the hospital. So what are some of our barriers to implementing a same-day discharge program? One of them is a change in traditional practice patterns. As I noted earlier, in the US, the vast majority of interventional cardiologists keep their patients overnight following elective PCI, and that's just been the tradition. However, if we look at a growing body of evidence, we see that hospitalization can actually pose hazards to patients. Things like infectious colonization, drug errors, other accidents, these could put patients at real risk, and a lot of the times patients are just safer being at home. So one way to overcome that barrier is just to realize, to educate physicians on that. And the other thing is the growing body of evidence has shown that patients prefer same-day discharge. They're actually really happy with that. Another barrier is medical legal issues. We all know as physicians that when we deviate from standard practice and an adverse event happens, we open ourselves up to potential lawsuits. And in fact, the SCI organization, which is the Society for Cardiovascular Angiography and Intervention, they came up with a consensus statement and guidelines on the appropriate length of stay after elective PCI. And in 2009, they published that patients should be kept overnight following elective PCI. That's the standard of care. But over the past 10 years, with all the data and evidence coming out, they actually changed things. Last year, they published a new guideline showing that same-day discharge is actually feasible in a select group of patients. And we'll talk about that in a little bit. Other barriers include procedure-related. If it was a complicated procedure, it was not successful, and patient-related factors such as lack of transportation, inadequate social support, if the procedure was done late in the day to facilitate a same-day, it might not be safe to facilitate a same-day discharge. So this is the consensus statement and guidelines from SCI. It was published in 2018, and this is essentially a summary of what they discussed, and they essentially incorporated three criteria, the three Ps. They look at patient-related factors, procedure-related factors, and program-related factors. So if you just look at the left side, if you can satisfy those three groups on the left, then the patient can actually be discharged home safely that same day. So things like, is the patient clinically stable? Are they at baseline functional and mental status? And are their comorbidities all at their baseline? Procedure-related factors are, was the procedure successful without any complications? Did we achieve adequate hemostasis? And then program-related factors are adequate social support, patients are educated appropriately, they're compliant, we have a good plan for DAPT, and we have a good plan for timely follow-up. And that just summarized what I was talking about. So this is actually a chart published by a group out in WashU in St. Louis last year, and it actually incorporated what the SKY folks were talking about. So if a patient comes in for an outpatient elective PCI, they do a prospective risk assessment of major things like bleeding, acute kidney injury, and then they use other criteria such as whether it was a successful PCI, were there any ischemic complications, and then based on all of those factors, they make a decision on whether the patient can be safely discharged home that same day or whether he or she requires overnight observation. So what do we do at NCMA? Well, I'm going to speak on behalf of myself. I'm not sure what my partners, Dr. Coleman and Dr. Patel, do. I'm sure it's something very similar. But what I look for is really 6 criteria. And these are the 6 criteria. Essentially, if the patient is low risk, meaning if they have no comorbidities or very minimal comorbidities. Do we do a radial approach? Was the procedure successful without any obvious complications? Did we achieve rapid and reliable stabilization of vascular access site? And then we look at patient factors, kind of like, do they have a good support system at home? Is the patient compliant? And do we have good, reliable provision of DAPT? If we can satisfy all those 6 criteria, then I'll discharge the patient home that same day. So in conclusions, same-day discharge following elective PCI is safe, efficient, and cost-saving. It is typically preferred by patients. It results in a high patient satisfaction. It is widely practiced around the world and is increasingly prevalent across the US. The key is to identify low-risk patients undergoing low-risk procedures. And thank you.
I'm wondering, since the transradial technique seems to be safer and fewer adverse effects, what dictates radial versus femoral?
And that's a good question. The question was, radial PCI is safer overall. What dictates radial versus femoral? A lot of the evidence, the data that I showed, specifically outside of the US, a lot of people were discharging patients who had radial PCI or femoral PCI. They were discharging them home the same day. In the US specifically, it's more those patients who undergo radial PCI are discharged home the same day. And that's what I prefer right now. I mean, it's still kind of a new thing, but obviously radial PCI, because of the less vascular and bleeding complications, I'm more comfortable personally with sending them home the same day. Femoral PCI, the problem is even if you achieve adequate hemostasis, you're still uncomfortable with the fact that maybe they can have some kind of groin bleed or retroperitoneal bleed or pseudoaneurysm or other vascular complications that may not show up until within a 24-hour period. That hasn't been shown by the data, but personally, that's I would just advocate for radial PCI.
Can I ask a question? Hello? Can I ask a question?
Sure, absolutely.
Why would you do a femoral PCI if a radial PCI is so much safer?
That's a good question. Why would I do a femoral PCI instead of a radial PCI? For the physician, femoral PCI is much easier, just to put that out there. But a lot of the times, there's specific limitations why we can't do a radial PCI. 90% of the time, things go well. In a smaller group of patients, radial spasm is a limiting factor where you can't advance the catheters. Some patients have different anatomy where they have significant subclavian tortuosity. So getting the catheters down and trying to engage the coronaries becomes very, very difficult, if not impossible. And then the third thing is if someone has had a CABG, doing radial PCI via the right radial artery is very challenging. So doing it femoral is preferable.
What's your policy for patients who live outside of Santa Rosa in terms of same-day discharge? Like if they live in Lake County or, Ukiah or somewhere like that?
I guess I should have included 7 criteria. Huh? So, yeah, I mean, usually if they're within 20 to 30 miles, I'm okay sending them home. But obviously, if they live in Ukiah or further up north, keeping them overnight would be the prudent thing to do.
A little different topic is that, what's your take on aspirin primary prevention in patient with sort of a few moderate risk factors such as high blood pressure, high cholesterol, but does not have previous coronary artery disease or peripheral vascular disease or diabetes? Is aspirin still recommended or not based on the recent study?
So I personally never actually advocated aspirin for primary prevention, even before the latest guidelines. So if a patient came in without established coronary disease or peripheral vascular disease, me personally, I just never put them on aspirin for primary prevention. So the new guidelines came out and now say that aspirin is actually not recommended for primary prevention any longer. And they keep going back and forth. So it's really kind of a physician based decision. Some physicians still do aspirin for primary prevention regardless of the new guidelines. I personally don't.
Thank you, Ali.
Thank you.